Good morning, Dr. Shah. Nice to see you. Nice and fresh, sipping coffee there.
Good morning, Anil. How are you?
Well,
I
well,
can't
well.
see you on the video, but I'm sure I'll be able to see you.
I've turned my camera on.
Okay, now I can see you very well.
Lovely. A pleasure.
You, you
A
look
pleasure.
as young as you were here as a fellow.
Why do you always rob my lines from me? I wanted to use that to you.
You know what that means? It means very simple thing. You were looking old then, you look old now.
Wow. Anyway, we are looking forward to you. The response has been very positive. Thank you so much for agreeing because
Anytime, my pleasure.
yeah, and thyroid and you are synonymous, and many people said that Dr. Shah's, they were looking forward to him. It's excellent. Thank you so much.
Well, I'm honored.
Kanav, quickly, we'll just go over the housekeeping. I know others are also logging in on the same thing.
Yes,
I,
sir.
I see that you will give a welcome address. Then we'll do a clinic for about 45 minutes. We will keep the clinic at the level of an MCH student, DNB student. Is that what's expected?
Yes, sir.
And maybe, Dr. Shah, if I can make any, if I can request you, you can take it a notch higher because there are a lot of non-students also who will log in. So if
Sure.
anything new from ATA, anything new that's being done in Memorial, I think those kind of points, because there are a lot of practicing clinicians also who will join us.
Sure, happy to.
Yeah.
As the discussion goes on, I'll be happy to chip in.
Yeah, and then after that, Kanav has an interesting case which will just kickstart. And what I thought is I'll open it to the audience to send in uh, whatever doubts they want or any points they want. So if there are any Q points that they give us, like someone wants your view on active surveillance or something like that, then we can, shoot those questions. You can give your perspective. Dr. Pradhan can give the Indian perspective. I'll chip in and anybody else who wants to be part of the contributions. Is that okay?
Perfectly okay.
Oh, sir, you're there. I thought you're not. You'll be operating, sir. Can we see you?
Sir, shall we begin?
Yeah, please. And Kanav, when you make your announcements, you can tell them to post any questions on the chat, which you and me will look at from time to time, and we can put it to the group.
Yes, sir.
Okay, go ahead.
So good evening, everyone. I welcome you all to the first session of the grand rounds in head and neck cancer. This is an initiative that has been started from the Head and Neck Cancer Institute of India in Mumbai. This is an institute that is the vision of Dr. Sultan Pradhan, and this has been, the hospital was started in August 2023. So it's now close to 2 years that this hospital has been running. So today the first session will be on thyroid cancer, and we have three stalwarts in this field with us today. There is Professor Ashok Shah, Professor Anil De Cruz, and Dr. Sultan Pradhan. So I request Dr. Pradhan to give a brief. He would like to give a brief introduction about the hospital and our faculty today. So today we'll have Dr. Kartika Rao, who is an MCH head and neck oncology student. She'll be presenting a case. This will be a discussion for the first 45 minutes, followed by various different scenarios that Dr. Anil De Cruz sir will moderate in the next hour. We will also be open to questions from the audience, so everyone can post the questions that they have and direct it to any particular person if they wish, and we'll address them in the session. I think Pradhan sir has connected. We'll just address, give us a brief overview, and then we can start.
Where are you from, Kartika? Your mic's off. Your mic's off.
Welcome. Sir, I'm from Mumbai itself. I have done a 1 year fellowship with Dr. Pradhan sir last year, and I just gave my NEET exam, and I'm going to start MCH right now. I just cleared the exam, so I'm going to take admission and start now.
Wow, congratulations. Where you're doing it at Tata's?
No, sir, I took in Amrita.
Oh, nice place. Okay, good. Congratulations to you.
Thank you, sir.
Kanav, is Dr. Pradhan logged in? Otherwise, Kanav, we'll start the case and sir can speak later in between. I think between the two cases, that may be better. Because there are a lot of people who have logged in. I can see there are over 100. Kartika, we'll start with you. You can present. Dr. Shah, may I request you? It's an exam format. There are a lot of students. Please feel free to jump in and stop her in between and ask for justification. You've gone through the Indian system and you're familiar with how the exam goes.
No problem. Happy to help.
Okay, go ahead, Kartika.
Yes, sir. Just 1 minute. Sir, is the screen, is it visible, sir?
Yeah, it's visible.
Yeah.
Just
Go
put
ahead.
it. Yeah, go ahead. Perfect.
So good evening. I'll be presenting a case on thyroid, on a thyroid case. So my patient is a 37-year-old gentleman who is a businessman by occupation, a resident of Surat. He has presented with the chief complaints of a swelling over the anterior aspect of his neck for the last 5 months. The patient was asymptomatic 5 months ago when he noticed this swelling over the anterior part of his neck. The swelling was insidious in onset and it has gradually progressed to its current size. The patient does not give any history of change in voice or difficulty in breathing or swallowing. There's no history of pain associated with the swelling, no history of radiation exposure in the past, no history that was suggestive of hypothyroidism or hyperthyroidism, no other neck swellings, no history of any other neck swelling, no history of cough, breathlessness, bone pain, or hemoptysis. The patient does not have any comorbidities, no family history of cancer, no past surgical history. His sleep, appetite, bowel, and bladder habits are not significant within the normal. He's normal. He does not have any addictions and consumes a mixed diet. So should I summarize to summarize my history? He's a 37-year-old gentleman who has presented with an anterior neck swelling for the last 5 months. It was insidious in onset and it has gradually progressed in size. There's no history suggestive of any hypo or hyperthyroidism, family history of cancer, or any past history of radiation. Should I proceed, sir?
Perfect. Sir, you want to make any comments, Dr. Shah?
No, I think, you summarized the history quite well related to thyroid. So the next thing is, where do we go from here? So you have to give us the clinical findings and
Yes.
what you feel, and then we'll come to the investigations.
Okay, Kartika, I'm going to ask you on your summary, as you read these 4 lines, what doesn't fit into a thyroid? What's a little different from a normal thyroid presentation in this? Can you comment on the third word on this, on the first line? Is thyroid seen normal in males, females?
No, sir. Sir, in there's a it is usually thyroid swellings are seen. They have a higher frequency in the women, and when seen in the, it's a 5:1 ratio, female to male ratio, and usually the frequency of cancer presenting in the nodules is higher when it is seen in the males.
Okay. So an important point is your index of suspicion, if it's a male patient presenting, should be higher on your history. And whenever you give the history of a thyroid swelling in your exams,
Hmm.
you must cover three aspects of the thyroid swelling. One is the swelling itself, the history of how it's grown to its current size.
Hmm.
You must cover hypo and hyperthyroidism, which is very, very important.
Hmm.
Then you must look for etiology, and you put that family history, you put prior radiation.
Yes.
Sometimes some examiners want to know a drug history and a history of from where the patient comes, because these are very important for endemic goiters in our part of the country. There are certain cardiac drugs that can cause goiter. Goitrogens, that is when you eat a lot of cabbage, brassica family, those can cause goiters. So examiners wait for these three, four, and the last, your history should be broken into any pressure effects, that change in voice, breathing difficulty. These days, we don't see those kind of advanced cancers, but these four broad headings should be in your mind when you present to your examiner. Okay, go ahead. Great. Have you got a tentative diagnosis at the end of history in your mind, or it's just a simple goiter?
Sir, I had two. One is a goiter, or it can be a malignant etiology.
Okay, go ahead.
On general examination, he was very much within the normal limit. The patient is conscious, cooperative, well oriented to time, place, and person, well built and well nourished. He had an ECOG score of which is 0. His vitals were within the normal limits. No pallor, icterus, cyanosis, clubbing, pedal edema, or lymphadenopathy. There were no eye signs elicited that were suggestive of any severe hypothyroidism. No other signs of hypothyroidism or hyperthyroidism. On local examination, on inspection, I inspected the patient in a sitting position, and he has an anterior neck swelling, which is approximately 3 by 3 centimeters, mainly on the right hand side. That extended from laterally from the anterior border of the right side sternocleidomastoid to just about the midline, 2 centimeter below the thyroid notch to around 2 centimeter above the suprasternal notch. The skin overlying the swelling is normal. The swelling moves on deglutition. The lower border is visible. On palpation, the swelling was firm in consistency. It had a smooth surface and well-defined edges. The lower border of the swelling was palpable. Skin over the swelling normal. Trachea was in the midline. Bilaterally, the carotid pulsations were palpable. They were not displaced. There was no palpable lymphadenopathy. I did the Hopkins examination, and bilateral vocal cords are normal and mobile, and systemic examination was within the normal limits. So, to summarize my to summarize the history as well as the examination, I've already mentioned about the history. On examination, there's a 3 by 3 centimeter square swelling in the anterior neck, which is mainly on the right hand side, form smooth and well defined, doesn't have any retrosternal extension, and no palpable lymphadenopathy.
So, Kartika, you are summarizing there is a nodule in the right side of the thyroid, correct?
Yes, sir.
In the 37-year-old gentleman.
Yes.
What's your diagnosis 1, diagnosis 2, and diagnosis 3?
Sir, the first diagnosis is a solitary thyroid nodule, and
Okay.
further like to do the investigations to
So
look.
before investigations, the person is in your office, he walks in, you have got 3 centimeter nodule in a 37-year-old gentleman.
So either I would keep it a benign nodule in mind, and the second one would be a malignant nodule.
So for all practical purposes, you have to rule out malignancy. Am I correct?
Yes, sir.
This is a thyroid cancer unless proved otherwise.
Okay, sir. Yes.
What is the risk of his having thyroid cancer? He has a 3 centimeter nodule in a 37-year-old.
So the risk.
Yeah, what is the chances he has thyroid cancer? 10%, 2%, 100%?
Some males have around an 8% chance of a malignancy in the cold in the nodule, whereas when compared to females who have around a 4% chance, 4 to 5.
I think your numbers are too low, too small. If you're talking about 3 centimeter nodule in a 37-year-old gentleman, the risk of malignancy is about 35%.
Okay.
So, Kartika, please understand the examiner's question very clearly.
Yes,
He's
sir.
asking you in this case, your answer may be correct for all nodules. If I went to, Churchgate Station and caught a number of men and then saw their nodules which are small, then your numbers are okay. The
Okay.
examiner specifically asking you, 37-year-old gentleman walks into your office, 3.5 centimeter nodule, then the numbers are much higher.
Okay, sir.
The first thing you need to tell this gentleman is, you have a problem. Don't run away from us.
Mm.
We
Yes, sir.
will do the investigations, but don't run away. This is something I'm concerned about. And if you don't convey it to him, he
Mm.
will go around thinking that he has a benign problem. If you tell him the risk of malignancy is 8%, he will say, I don't worry about it.
Okay. Yes, sir. Yes.
Go ahead. What's your next investigation? You examine him. You
Yes.
gave pretty good information. You
Mm.
look at the vocal cords. Why did you look at the vocal cords?
Sir, as one as a because I'll be considering for the surgery to see if there is any pre-operative documentation of any vocal cord abnormalities.
Okay. Keep going. What's your next investigation?
So I next investigation first I did a thyroid function test. The TSH is 5.82, slightly in the upper value of the reference range. T3 and T4 were within the normal limits. Uh, Next, I did a
So the patient is in your office. You're going to do the blood test today and tell him to come back in a week. Is that the plan?
so immediately first I'll send him to give the blood test and at the same time tell him to do the sonography and come to me with the sonography. So
All
that
these investigations need to go parallel, hand in
okay,
hand.
okay, so
That's why I told you right in the beginning, a 3 centimeter nodule in a 37-year-old man is cancer unless proved otherwise.
mm.
Go ahead. What are the ultrasonographic findings you are going to worry about?
So on ultrasonography, there was a 3.4 by 2.6 centimeter well-defined solid hypoechoic nodule in the right lobe of the thyroid. The nodule was taller than wide, had microcalcifications and increased vascularity and no evidence of extrathyroidal extension. It was reported as a TIRADS 5. The left lobe of
What
the
is
thyroid.
thyroids?
So TIRADS is the staging system based on the ultrasonographic features. The full form is Thyroid Imaging Reporting and Data System.
Good, very good. Go ahead.
So the left lobe of the thyroid is normal and there were no abnormal lymph nodes in the central or even the lateral compartment. Then next is we did a, USG sonographic guided FNAC of the right thyroid nodule, which which said it was suspicious of papillary carcinoma Bethesda 5.
So,
Okay.
Kartika, on this slide, what all tells you that it's malignant?
So starting with the TSH, because it's on the upper level of the reference range, so that is indicative of it's usually seen in the malignancies.
Excellent. That's what I wanted. That's all. That people should be aware for the other students that when you get on the upper side, a hypo is more towards malignancy than a hyper. So that's an important point that you've picked up, and the others are okay. Absolutely fine. What do you mean by taller than wide? Why is a nodule taller than wide?
Sir, that is because of usually in papillary thyroid carcinomas, there's a fibrosis that occurs because of which when you put the ultrasonographic probe, the compressibility is affected, and hence you get that taller than wide picture more than the wider than tall.
Excellent. And the last thing I wanted to ask you is what staging system do you use for thyroids? Can you name some staging systems? Are they different staging systems? It's one uniform. You're an MCH candidate. That's why I'm asking you.
Yes, sir. Um,
Which is one of the most widely practiced thyroid system? Is there Korean thyroids, a Japanese thyroids, a European thyroids, an American thyroids? Which system is most widely practiced?
Sir, not aware. Um,
See,
is
doctor,
American, sir, American.
now remember one
Yes,
thing in life, whenever you don't, it has to be American. At least
American, sir.
clarify
Yeah.
you. Dr.
Yes,
Shah,
sir.
you could have seen from his. And in American, there are two very commonly practiced, ATA and the ACR.
Yes, sir.
Dr. Shah,
Yeah.
which one do you all use? Are you all more towards ACR again for the other people listening in?
Well, it's interesting you are asking this question. I think it's $1 million question. We have been kind of metamorphosing in the reporting of the ultrasound. In the olden days, they wouldn't report by thyroids. Now, majority of the private institutions and ultrasonographers are writing all the details of the thyroids. Like each classification that she described, they will say thyroid 1 or 2 or 3, and the total sum will be given thyroid 5 or 6. The memorial still uses the ATA classification, which is a high risk, low risk, intermediate risk. Again, that depends upon the institution. And when you get the report, you need to know how your sonographer is reporting it. If you don't get that information, it is not going to be helpful to you. Now, the description here is very classical of thyroid cancer: microcalcification, increased vascularity, taller than wide. I think those are the classical of thyroid cancer.
Yes.
Yeah. So, Kartika, again, quickly for the exam, AT and ACR are the two most widely used, and ACR gives a point score.
Yes,
And
sir.
the closer you go to 7, the more likely it's going to be malignant.
Yes,
I'm
sir.
going to read out certain words from your report, and you tell me what's the opposite, which is not malignant. Solid.
So purely cystic and spongiform.
Excellent. Hypoechoic.
Iso to hyperechoic.
Excellent. Uh, Taller than wide will be wider.
Wide.
Microcalcification.
Macro calcification or rim calcification.
Macro also has a point scoring on that, which is 2 compared to 3, but
Okay.
comet tail shadowing probably and increased vascularity. That's fine. Okay, go ahead. Who was Bethesda? Who was Bethesda?
So Bethesda is the place.
Okay, great. Okay, excellent. Because someone once told me he's a pathologist in Memorial Sloan Kettering. That's why I asked you. Okay, go ahead.
Where is Bethesda, Kartika? And why this system has been used? Why the name Bethesda came?
So there was a meeting held in 2007 for staging a
Correct.
uniform pattern for cytology, and that was in Maryland, USA, Bethesda.
Yeah, that's where NCI and NIH are. And it is interesting, even up to 2008, we didn't have the standardized reporting system.
Okay.
In UK, system has been there for more than 20 years or 25 years. They used to call Thai 1, Thai 2, up to Thai 5. In the United States, we change it to Bethesda 1 to 6. 1 and 2 are generally benign. 5 and 6 are strongly suspicious of cancer. And 3 and 4 are indeterminate or atypical. And we'll talk a little more as we go along with that.
Okay, Kartika, last question. Quickly, in 3, 4 words, tell us an FNAC technique you use.
Sir, it has to be a fine needle.
Fine, how fine?
22 to 23 and 25.
What happens if I put in 18?
So it will be too large, and you will get a lot of the sample will not be, you will not get a cytological study then.
Why? The bigger the bore, I should get bigger cells.
So when you apply the suction, when you apply the pressure, then you will get more amount of tissue. It will not be a cytological diagnosis then.
That's a true cut biopsy. It may make me better if I get more tissue.
Okay.
Is it because of that, or because you might draw blood, you might traumatize?
Yes, sir.
You just need a fine needle is more compliant to the patient. You get adequate cells. You're able to get your information with more than 90% diagnostic accuracy. And that's why we don't put in a big needle. Is there any other technique you use when doing an FNAC?
So one is with aspiration and the other one is non-aspiration technique. So,
Absolutely. Okay. Do you know something known as Zagdilla's technique?
so he was the one who gave the name for the FNNAC.
Maybe when you don't use the hub, you just, you don't put the negative suction. For very
There's no.
vascular lesions, you can just poke the hub in and then take it out and squirt it on a slide. That may be easier if you draw blood on negative aspiration. Okay, perfect. Go to the next. Sir, Dr. Pradhan, do you want to ask anything, sir?
No, I'm fine.
Oh,
Karthika, I'm just going to ask you one question. This is more like educational. You talked about fine needle biopsy. When would you recommend a core biopsy that Dr. De Cruz was talking, number 18 needle? When would you recommend in thyroid?
So if you want to diagnose a lymphoma, so we can
Yes.
do a biopsy because one is that, and
Yeah, you are right. Absolutely correct. What else?
um,
Which other condition where that would warrant a histopathology rather than just a cytology?
so even in to prove a anaplastic and poorly differentiated.
It took a long time. The answer was with you. Go ahead. You are absolutely correct.
Okay. So this is my last slide, so we can now add the investigation. This is the last slide.
why didn't you do a CT scan on this fellow?
Um,
Why I don't see any axial imaging. These days we do PETs, we do CTs, MR. You've only done an ultrasound and you've come home.
uh, So there was no indication to do the CT. According to the guidelines, we do the CT when there are large bulky cervical lymph nodes, or if there is any suspicious of an invasive thyroid cancer. So based on my history and clinical examination, he didn't have any signs that were suggestive of any invasion into the laryngotracheal framework, and neither did he have any lymph nodes that were palpable or which were seen on ultrasonography. So I didn't do the CT scan.
I would say partially correct. People can have invasion without symptoms. Are you aware of that?
Yes, sir.
50% will have hoarseness or hemoptysis. 50% will have nothing at all.
Okay.
I might go in and operate on a thyroid, which is looking mobile, and suddenly I'll find the recurrent laryngeal encased with disease.
Okay.
So how are you forewarned when you want to do a CT scan in your patient? So symptoms, I agree, but in 50% of people, they won't be symptoms. Sometimes swallowing, moving freely up on deglutition can be fallacious. If it's a big thyroid that's going behind, the top part will look like it's moving and you might miss the extension. Among the investigations that you have shown, what will give you a clue that you should do axial imaging?
So considering the size of the considering the size of the nodule,
Excellent.
and because these are all features that are favoring a diagnosis of a differentiated cancer, so and he's a young male, so we can ask for the CT scan for an axial section to
No,
also see the central compartment lymph nodes.
no, that is one thing to see lymph nodes, but the important thing is your sonologist must give you a clue. So I'm giving you a clue. On sonography, when will you be guided by a sonologist to do an axial imaging? Okay, location of the nodule.
Location. Look, and if the sonography has lymph no,
No
la,
lymph nodes. I'm saying nodule. Dorsal or ventral. When will you be more prone to do a
okay,
CT?
sir, if there is a more posteriorly located nodule which
Dorsal
is
location.
okay.
So the right answer is whenever you get a nodule
Hmm.
which is touching the posterior capsule, there is no thyroid tissue between the nodule and the posterior capsule, you must ask for an axial imaging. Or you have a large malignant nodule that is replacing the entire thyroid, then again your threshold to do an axial imaging will be lower, and of course to see nodes as well. Is
Anil,
that
there are
clear?
two questions. I think they are directed to us. So let me
Yes, sir.
take them. The one is Professor Abdul Karim has asked, all patients get CT scan at Memorial. Let me make it very simple. You know, our threshold for doing a CT scan is very low. We generally do it very commonly. The reason is very simple. This patient has thyroid cancer. You want to do the operation, you want to get the best evaluation first time. You don't want to do the surgery and in 6 months later, somebody does the ultrasound or a CAT scan and there are lymph nodes in the right side. You will feel very unhappy that I didn't do full evaluation. That is number one. The second thing is, it is easy as a surgeon for me to look at the pictures and get a three-dimensional view of the entire thyroid. That is what I call looking at the 360-degree view. The ultrasound is a good exam, but it is, the dependent upon who does it, who looks at it, and it's a serial pictures. In the operating room, what helps me most is looking at the CT scan. Is there a gross extrathecal extension? What has happened to the trachea? Are there lymph nodes in the central compartment which you cannot evaluate with ultrasound? Are there suspicious lymph nodes? Now remember, every young man has a level 2 lymph nodes from the old throat infection, tonsillitis. So you need to negate that. There are certain characteristics on the CAT scan which will help. Now, the reason people were against CAT scan for a long time, even in United States, was the use of iodinated material or iodinated contrast dye will delay the radioactive iodine for a few months. But remember, nobody gets radioactive iodine for 4 to 6 months after surgery. So that point is taken away. The new guidelines in 2015 strongly recommended cross-sectional imaging. So I think we do that. There is one other thing as a surgeon, and Karthika, you are a surgeon, so you should be familiar. When you do the CAT scan, do it with contrast, number one. Look at it yourself to see if there is retroesophageal innominate artery. And radiologists will not report that. You need to look at it because if it is there, then you know that the right nerve is non-recurrent. So always look at the CAT scan yourself, look at the paratracheal lymph nodes. If the patient has medullary thyroid cancer, more likely there are mediastinal deep paratracheal lymph nodes which you won't see on ultrasound. There was, I think, another question about the closeness of the vessels. Remember, any thyroid mass is going to be close to the carotid artery. So that doesn't make any difference. I don't think that is a major indication for CT scan. But a large mass, this is 3.4 centimeter. The chances he has nodal disease is very high. So I would do a CAT scan.
Devendra has a question. He's saying some no need to wait. Devendra, you can turn your mic on and please ask your question. It looks like a
Can you hear me?
Yeah, we can hear you. Go ahead.
So I had a query. Dr. Shah said that we can wait. We have to wait for 4 to 6 weeks. So what is the washout time for this radioiodine? Because nowadays you can use recombinant TSH. You don't have to wait for 4 to 6 weeks to make the patient hypothyroid. You can use recombinant TSH within a week after the wound has healed and give the patient an iodine scan quickly and decrease his treatment time. So I would like a clarification on that.
So I think, the question you are asking is a little bit split. Can you do the radioactive iodine within 4 to 6 weeks? Yes. With thyrogen, you can definitely do it, recombinant TSH. The question is, iodinated contrast dye, where there is a serum high level of the iodine, which will kind of derange your practice of doing radioactive iodine soon after surgery. So those are the two split. Can you do it within 4 weeks? If the patient did not have CAT scan, yes, you can do it. If the patient had CAT scan with iodinated contrast, you need to wait about 2 months. Sometimes what we do in Memorial, we'll get urinary iodine to make sure that is normal level.
Okay, Devendra, I don't think there's any urgency in my book to rush into radioiodine within 2 weeks after surgery. If you have to do it, you can always do it a little later. But quickly to answer, there is a nice study in the 2015 ATA, the Italian study quoted there, where they show washout by 4 weeks, all the iodine is out of your system. So many people, as Dr. Shah said, do CT scan, get scared of iodine. The information you want on nodes and vasculature and parts of the larynx better seen with iodine. So always give the contrast. And these are all water soluble, unlike the old days when we used to give iodine, which never, I mean, the contrast which never used to get absorbed. We used to do myelograms and those kind of things. And that's the reason why this big fear came. So I think it's a moot point when you want to do it, but 4 weeks, after 4 weeks, you're good to go even with the withdrawal system on your radioiodine treatment. Kartika,
Yes, sir.
I'm going to call out an investigation. Tell me when you'll do it. Okay?
Yes, sir.
CT scan to see extrathyroidal spread, laryngotracheal invasion. MRI scan.
So for esophageal and vascular involvement,
Excellent. PET scan.
uh, not in if you have a so it's not a preoperative in papillary thyroid cancer, but if you're suspecting poorly differentiated or anaplastic or medullary, then we can do the PET scan.
Okay. See metastatic disease and aggressive histologies. Perfect. Excellent. Okay. Good.
Yes, sir.
What will you do for this patient now?
Uh, Sir, the considering so the nodule is a 3 by 3 centimeter square nodule. So for nodules which are more
Okay, before you jump into that, let me just ask you, describe a papillary cancer smear on the slide. Just give me 2, 3 words that the examiner is looking for. Old timers like me, Dr. Pradhan and Dr. Shah want 2, 3 words and we'll pass you.
So one is the characteristic orphan annii appearance of the nucleus, nuclear enlargement, atypia and chromatin clearing with pseudo inclusions and grooves.
Excellent. Perfect.
You don't need to do MCH now.
Even again, you stole my line. I was keeping it for the end of our presentation. Perfect.
Very well done, Karthika. Go ahead.
Very well done. Perfect. Okay, go ahead.
Sir, to proceed, so for because it's a 3 by 3 centimeter square nodule, uh, according to the guidelines, we should actually offer him either bilateral thyroidectomy or we can do the hemithyroidectomy. Sir, I was little.
Wait. Bilateral thyroidectomy. It's a Bethesda 5. What's the possibility that it's malignant?
So in a Bethesda 5, it's around 75 to 85%.
Great. So you operate this guy, you do a total thyroid, you fix a cord. He's on 14 tablets of calcium post-op as complication. He goes to Memorial, comes back and the report comes as non-malignant. Possible, not possible.
No.
He takes you to court.
Yes.
But you said confidently, first surgery, total thyroid.
So we've
Justify. You may be correct. I just want to see your justification.
So I was going to say that we can do a hemithyroidectomy or a total thyroidectomy, but after explaining to him the risks and consequences of both.
No. I am asking a very specific question. If you told me correctly, Bethesda 5 is not 100% malignancy, why should you explain him and do a total thyroid? Just justify it.
The total thyroidectomy is one because he's considering that he's a male. So there is a higher chance of malignancy, and he has a nodule which has developed in the right lobe. So he can go on to develop in the left lobe. Second, on doing the if there are any aggressive histology that will come in the final histopathology report, then that would warrant an completion thyroidectomy so that he can be a candidate for the radioiodine study.
So
So
that means in your book, there is no role for hemithyroid, because in my book, anybody can have multicentric disease. And in any patient, you can get a histological surprise of a aggressive variant. Why in this patient it should be a difference? That means what all these people are saying for years, there's a role of hemithyroid up to 4 centimeters. In your book, there is no role.
no, hemithyroidectomy, sir.
No, you may be correct. I'm just trying to confuse you. Nasty examiners do that.
So in first I was thinking that
Dr. Shah, the co-internal examiners takes up for the candidate. You might want to bail her out, or maybe Dr. Pradhan should do that because she's a HCI girl.
Will you confirm the diagnosis on frozen section, or you just go ahead and do a total
the
thyroid?
first actually I'd explained to him to do a hemithyroidectomy, and then intraoperatively, if there were intraoperatively send it for frozen section, and also if there is any evidence of any extrathyroidal extension or any lymph nodes that we see intraoperative, then at the same time before taking him up for surgery, take the consent for a total thyroidectomy.
You're playing with fire. I can see Dr. Shah getting a little. So tell us the role of frozen in thyroid.
That's what you picked it up very well. I think the role of frozen section for native thyroid is very, very low. I'll tell you, when you send this for frozen section, they're going to say suspicious thyroid tumor. They're not going to tell you anything more. That's not going to change your mind. What is more important is your radiological pictures are strongly suspicious of cancer. He's a young man. He has a very well-defined nodule. All that you need to do is go to the pathologist or the cytologist and say, hey, you put this Bethesda 5. How close you are to Bethesda 6? And the cytologist will tell you, I think it is thyroid cancer. I don't have enough cells to put it on paper. That's more than enough. Now, the role of frozen section for thyroid itself is very minimal. If you send this to our pathologist, they will call you and say, do you really want frozen section? I'm not able to see the whole capsule. I won't be able to see the whole architecture. And I need 3 pathologists to look at it and then answer you. But the role of frozen section in thyroid is mainly for the lymph node. Or you are seeing a parathyroid and you're not sure, is this a parathyroid? Is it a lymph node? Then only there is a role. Otherwise, there is very little role of frozen section in thyroid.
So you got that,
Yeah.
Kartika?
Yes.
Even for a PAPCA?
Yes, sir.
Even in PAPCA, you're not going to be able to confirm that this is a carcinoma?
Dr. Shah, you may want to answer it.
I didn't get the question very well.
No, Dr. Pradhan's asking in PAP-CA, even in PAP, is frozen of no use?
In follicular carcinoma, the frozen is very
Oh yeah, that's great question. Definitely, in follicular carcinoma, the report is going to be follicular neoplasm. Wait for the capsular invasion to be studied or vascular invasion to be studied, which will take about 3-4 days. It is not going to help you. For papillary carcinoma, maybe they will be able to tell, but your decisions are already made the minute the patient walked in your office. You know exactly what you're going to do. The imaging studies don't show anything in the opposite lobe. You don't see any lymph nodes suspicious, large lymph nodes. Now remember, the ATA divided between the bulky nodal disease with minimal nodal disease. Finding couple of lymph nodes, positive lymph nodes in the paratracheal area is almost a given. That's how the papillary cancer behaves. And I don't think this patient deserves a total thyroidectomy at this time. That's my personal feeling. And I think the ATA has kind of substantiated that or supported that all along. I just want to add one more thing. In United States, now we're going away and away from routine use of radioactive iodine. The routine use of radioactive iodine was the concept of old time. It doesn't help the patient. It hurts the patient more because they get chronic sialadenitis. There is a higher risk of complications and some risk of developing second malignancy. Now, that is very difficult to interpret because of the epidemiological studies, but we know these patients will end up with chronic sialadenitis. That doesn't help. And you can argue that there may be a microscopic cancer on the other side today, or the patient may develop one in future. But that is there in 5% of the world population. Either me, Dr. Pradhan, you, or Anil may have a microscopic papillary cancer. We live with it, we grow with it, and we peacefully die with it.
So Kartika, and for the others, I'll just paraphrase what has been discussed in the last 4-5 minutes. What Dr. Shah said, that he would go to the pathologist and ask. So to put it for your examiners, each institution should know exactly the risk of malignancy with their group of pathologists. So I'll tell you, when I was at Tata's and we looked at Bethesda, a Bethesda 5 was 100% malignant. They just did not have enough cells to call it 100% Bethesda 6. So you don't walk to any pathologist and ask them what they feel. You should have your incidence for your group of pathologists with which you work across all the Bethesda stagings. And a point is, if it's a lower Bethesda, then you may want to take a second opinion on your slides because it depends on the experience of your pathologist. To answer Dr. Pradhan's question, absolutely frozen is of no use for follicular because you have to see capsular and vascular. You need to sample that capsule very carefully, which cannot be done in frozen. Yes, there is meta-analysis data to show that the diagnostic accuracy of a frozen is higher for a papillary lesion than a follicular. But it's not 100% because some of the classical nuclear features that you see are better seen on fixed slides than on frozen. So yes, they may be able to tell you it's a papillary, but it's not like the diagnostic and sensitivity is close to 100%. They can goof even on that. But what I do very often is just fish out a node and send it, because any pathologist and even a non-pathologist like me can see a met in the node and tell you, yes, this is malignancy, and you can go ahead with your total thyroid if that's your philosophy. That we'll discuss now subsequently. Okay?
Yes.
Okay, question to you. FNAC, this is easy. We're going to operate and we'll go home, we'll make our money. FNAC put in Bethesda 4.
Yes, sir.
Bethesda 3, Bethesda 4. What will you do for this guy?
Sir, according to the Bethesda guidelines, we should offer him molecular marker analysis. So if he's able to afford that, then we can go ahead and do the molecular study. Otherwise, we can do the hemithyroidectomy, and then based on the final histopathology report, counsel him if he would require a completion thyroidectomy later.
So great question. Nasty examiners will ask you, Kartika, how often have you seen molecular markers done for a Bethesda 4 at HNCI?
Sir, we don't do the molecular marker study here.
So we want to treat this guy. We don't want your theory from Bethesda.
So we'll do the I'll counsel him for a hemithyroidectomy, and based on the final histopathology report, once that report, we study that report, then I'll at the same time tell him that he may or may not require a completion thyroidectomy at the second stage.
Okay, so he tells you, no, my girlfriend likes this nodule. She feels it from time to time. Can I avoid surgery? You are saying that it's not malignant. It's a Bethesda 3. I don't want to get operated. It's a Bethesda 4.
So we can give him I can give him an option of reviewing the cytopathology slide one more time.
Review. I told you I'm a nasty examiner. It comes back as Bethesda 4.
Sir, Bethesda 4. So I'd explained to him that a Bethesda 4 has a 30% chance of malignancy, and to give him better information about the status of that, so I'd advise him a hemithyroidectomy for diagnostic purpose.
Which Bethesda 4 will you observe, or will you operate all Bethesda 4? Which Bethesda 3 will you observe, or will you operate all Bethesda 3? Because even in a benign, there's a 5% chance of malignancy. So I see young practitioners in our city, they're telling young girls of 22 with a 1.2 centimeter nodule, you're a Bethesda 3, there's a 5 to 15% chance of malignancy. Why do you want to take a chance? Get your thyroid out. 1.2 centimeter nodule, not even cosmetically a problem. So how would you advise? Which Bethesda 3 and 4 will you observe? Aishwarya is jumping with some half the answer. You can read it, but I would want you to answer. Then we are going to ask Dr. Pradhan and Dr. Shah their views, and maybe Devendra, if he's still there, or any other seniors. Do we operate all Bethesda 3 and all Bethesda 4?
Answer is very simple. No.
You have
Again,
to be,
a lot of that depends upon the
sir,
size of the
sir, 1
lesion.
minute, sir. You have to be King Solomon at the end. You are burying the question at the beginning only. Come on, Kartika. First, Kartika is the examiner. Please answer. Then Dr. Shah. He's already given the keyword.
Sir,
Okay, Dr. Shah, please go ahead.
Okay, so I think, whenever you get this report, Bethesda 3 or 4, a lot of things go through your mind. Number one, what's the risk of malignancy? What does it look like on ultrasound? What does it look like if you do the molecular testing? Now, I must paraphrase. The molecular testing are prohibitively expensive. It costs about $5,000 to $6,000 in United States. Now, why do we do it? Because the insurance company is ready to pay for it. If somebody has to pay from his pocket, nobody will do the molecular testing. In Chile, there is a cheaper molecular testing. They do about 12 mutations, and they are very good. It costs very little, but it's a different system. Again, the size of the nodule, the location of the nodule, very important if it is involving the isthmus or the posterior capsule, and that's where the CT scan may be of help. And the last but not the least, which is very important, what's the patient's psyche? Does the patient understand you very well? Is she willing to follow with you? Repeat ultrasound in 8 to 9 months. If the size has not changed, you can convince her that let's wait, see what happens. Now, if it is a 3 centimeter nodule in 25-year-old girl, the risk of malignancy is more than 50-60%. I would probably operate on her knowing very well that she can't live from the age 25 to 95 without surgery. So those are some of the features or issues that go in the discussion.
Sir, Dr. Pradhan, would you like to make any comments?
No, I think Ashok has said it all.
Okay. Devendra, anybody, any of the
Solid
other
nodule,
seniors or
solid-
anybody?
A solid nodule, a complex nodule, a nodule located into closer to the groove, you don't want to observe those. You want to take that out.
So they're multi-factors. Aishwarya, would you like to make a comment on architectural, what you had put up? If you are there, you can turn your mic on and you can make any comments.
Nothing, sir. Just wanted to tell that if there is nuclear atypia, then that would be having a greater risk of uh, being malignant, and which is why we might want to do lobectomy and send it for frozen, and then proceed with the total just in case that comes positive.
Kartika, did you follow what she said?
Yes, sir.
Okay, quickly again for the exam and for the exam going people to decide whether you operated a Bethesda 3 or 4, you look at multi-factors. What Dr. Shah said very correctly, you look at clinical factors. High risk people like nodules in kids, nodules in males, you will go towards a family history, were more towards surgery. Then you look at the size of the nodule. If the nodule is very big, then you'll do it. On investigations, you look at a thyroid scoring. If a thyroid scoring is high, you will definitely go for surgery in those patients. If the thyroid is low and he wants to observe, I may give him or her a chance to observe. And what Aishwarya is saying, there are studies that look at the smear. When you look at nuclear features and the architecture, if your nuclear features show more towards a Bethesda 4 then if the nuclear features are characterizing it to a higher Bethesda, the chances of malignancy in that nodule is higher. So you may want to fine tune your pathology reporting. Of course, if you have molecular, you go ahead and do it, but there's restrictions of cost and availability in our country.
Okay, sir.
Okay,
That's
great.
why, Anil, we call this diagnostic thyroid lobectomy. For
Correct.
Bethesda 3 and 4, if the size is big, if it is below 2 centimeters, there's nothing wrong in observing. What you need to tell the patient and the family, this nodule may have been there for last many years. You just didn't know about it, and I'll be happy to monitor you. See what happens in 6 months. If in 6 months it becomes like more than 5 centimeter big, yes, we know that she needs surgery. And majority of the time when we use the word diagnostic thyroid lobectomy, keep in mind it is a therapeutic thyroid lobectomy. It cures the patient with hemithyroidectomy alone. And we'll talk a little more about that prognostic factors.
So the take-home message for practicing clinicians that every Bethesda 3 and 4 doesn't have to come out. Many of them are females in the childbearing age. It's not a cosmetic problem or a barely perceptible nodule. Please look at it balanced and only take out nodules where you feel the indication is more towards malignancy. Rajdeep Naik has posted a question for you, Kartika. He is asking, why can't I do thyroid markers to find out malignancy? What's the role of doing thyroglobulin? What's the role of doing a calcitonin in a thyroid nodule?
The thyroglobulin is not done as a pre-operative test to decide about a decision regarding the surgery, because it can be elevated in inflammatory conditions as well. So we don't use it as a pre-operative blood test marker to consider for surgery. Calcitonin, so we do the calcitonin if we are suspecting the medullary thyroid carcinoma. So we can do the calcitonin considering, but in a young patient, we would not considering his age and if he doesn't have any family history, but otherwise we can do calcitonin.
No, but 80% won't have a family history. So I don't buy your answer that if he doesn't have a family history, if he has a family history, he'll walk to you in his pubertal age with a red proto-oncogene report or an MEN2B syndrome facies. Should we do calcitonin in thyroid nodules routinely? If not, when do you do in a thyroid nodule? This may not be at but you're an MCH candidate, and even there are other people in practice. There are some people who do for all nodules calcitonin.
So routinely, serum calcitonin is not indicated. And if we are suspecting a medullary thyroid carcinoma that we have got from the FNAC report, then we can do the serum calcitonin.
Dr. Shah, would you like to make a comment on when you will do a calcitonin?
Yeah, we have been debating about this for a long time. There was a famous endocrinologist in Pisa, Italy, Aldo Pinchera. He passed away a few years back, but he was a strong proponent of doing calcitonin. And that's why, if you look at the Italian guidelines, they strongly recommend calcitonin for thyroid nodules. And the reason is the incidence of medullary cancer in that part of the world is very high. In United States, it's less than 2%. So we don't do routine calcitonin unless the needle biopsy is suspicious of something spindly. If the pathologist says, I see spindly cells, then get a calcitonin. Or your clinical judgment kind of gives you a funny feeling that this looks very funny, or there is a distant family history, then I would do calcitonin. Routine calcitonin in 2015 guidelines were kind of kept to the judgment of the individual physician. They did not recommend strongly.
So we don't do calcitonin in all patients because it's a waste of money. It's not cost effective. 1 in 100 nodules will be medullary. So if you do it, you're wasting the number of, you're wasting 99 calcitonin tests unnecessarily. So as Dr. Shah told you, you will definitely do it when you suspect medullary, spindly, that your pathologist writes that. But I do it for majority of my patients in 3 indications. One, if it's a Bethesda 5, the patient has nodes in it, and I do not see the classical features of microcalcification XYZ on my sonography. Then my index of suspicion is very high on a medullary. So now when they say microcals, when they say taller than wide, these are all features towards PAP. I won't do it. But if they say like a woolly calcification or there's no calcification and I get a Bethesda 5, I would do medullary. Because at that time, surgery is my mainstay. I have to clear the nodes properly. I also, my threshold then of doing a CT scan is very low because I want to see the upper mediastinum. Satakshi, I saw you posting a comment on T3, on Bethesda 3 and 4. Would you turn your mic and please make that comment?
Good evening, sir. So is the same thing what Ashok sir just explained, that yes, calcitonin washouts in Bethesda 3 and 4 can be done, but the yields are low. I believe there are studies, if I'm not mistaken, from Japan group also showing that the yields are low, so it's not routinely recommended.
Okay, great. Any other comments from anybody? If you all want to make comments, just raise your hand. We'll ask you to turn your mic on instead of everybody turning it out. Kanav, you want to make any points? You're the chief coordinator and we've not asked you anything. Please go ahead.
No, sir. I think we can continue.
Okay, great. We are on the R, which is the R given to Kartika. The chief examiner, Dr. Shah, has already given you a gold medal and a degree. But I think I'm having fun and I just like to go on and we'll discuss the treatment, surgery, other philosophies rather than bring in cases. Would that be okay, Kanav, as the coordinator?
Yes, sir. Whatever helps with the flow, we can
Okay. Okay, sir. Is that okay? Dr. Pradhan, is that okay?
Yes, yes, Anil.
Okay, go ahead, Kartika. What will you do for this patient?
So we'll do the a hemithyroidectomy for him, and what if there's any intraoperatively, if you find any lymph nodes or if you find any extrathyroidal extension, then only I would have pre-counseled him to convert it into a total thyroidectomy. Otherwise, just hemithyroidectomy.
So is that correct? Is your philosophy to do the central compartment in all patients? Where will you look for nodes?
So
Lateral neck,
uh,
central neck, where will you look for nodes? So
so
you
along
will
the
do a hemi and you look for nodes. How will you look? With your finger, with your eyes, with dissection?
Sir, you have to dissect along the recurrent laryngeal nerve in the paratracheal area and look for the round blackish lymph nodes. So if you find those lymph nodes, then you have to send it for a frozen section.
So if you don't see blackish lymph nodes,
So if you don't see those characteristic lymph nodes, then you don't need to you don't need to just go around berry picking the nodes. So you can just do the hemithyroidectomy and then come out.
so in your philosophy, there is a role to do a central compartment on the side of disease for all patients of thyroid cancer?
No, sir.
Then,
Sir, inspection. We have to do only an inspection, but the inspection would involve inspecting along the recurrent laryngeal nerve and in the paratracheal area.
so you will dissect, that means, right?
Yes, yes,
You
sir.
will dissect.
Yes, sir.
So what we call and we propagate, it's called limited exploration of the central compartment. That's a term that's not widely accepted by people. It's a clinical practice. So what is the current literature about therapeutic or doing an elective central compartment versus observation?
So the the decision to do a elective central compartment, we don't do an elective central compartment unless uh, unless it is indicated. So it is only indicated if it's a clinically T3, T4, or of course if you have the clinically N1A lymph nodes, or if you have the lateral N1B, clinically N1B, then only you would do a central compartment dissection. Otherwise, as elective, you can observe you don't need to address the central compartment.
Why should you do central compartment if you have lateral neck?
So because the central compartment lymph nodes are the first echelon lymph nodes for the thyroid cancer. So that's why.
Sure,
Yes,
always
sir.
150%.
Yes, sir.
I'll answer it differently and see if my answer is better than yours. Or maybe we can add both the answers. If you have lateral neck positive, 80% of patients will have central compartment positive. And because it's such a high incidence, I'll always do the central if I have a lateral neck. Fair?
Yes, sir.
Okay. Dr. Shah, philosophy of central compartment.
Well, before that, I'm going to, since Kartika, we're trying to pull down Kartika. Why the lymph nodes in thyroid cancer are black? You told us right away that I would look at the black lymph nodes. They are characteristics of metastatic thyroid cancer. Why are they black? See, I know I have to get you somewhere, you know.
Sir, no.
And in which other conditions you get black lymph nodes? Okay, so I'll give you an answer. I have a philosophy. If you don't answer in 3 seconds, it's a time for jeopardy. You know, you move on to the next question, or the moderator gives the answer. So the answer is because these lymph nodes have hemosiderin-laden macrophages, which is characteristic of metastatic thyroid cancer. You do get black lymph nodes in melanoma, and you do get black lymph nodes in India in city dwellers because of the diesel and the combustion that you inhale all the time. The lymph nodes can be black. If there is a black lymph node in me, it is probably because I lived in India. That doesn't mean I have thyroid cancer. Just keep that in mind. Okay, so go ahead.
Or you've traveled to India. It could
Yes.
anyway, Kartika, those nodes are called anthracotic nodes. And an anthracotic node is normally seen in the scalene triangle. It's very common in the scalene triangle. It's rare in the central compartment because when you look at lung drainage, it goes up into the scalene triangle first. But the point is well made. So when you do a lateral neck dissection, if you see anthracotic nodes, don't hit the panic button. It may be in our country just because of carbon and those other deposits. Sorry, Dr. Shah, to jump in. Please go ahead.
No problem. I just want to get back to the whole philosophy of prophylactic versus therapeutic central compartment dissection. Now, we need to go back to the history. We never talked about lymph nodes in thyroid cancer before 2006. What happened in 2006? Something happened in 2006. The 2006 were the first publication of American Thyroid Association guidelines. And they wrote in those guidelines that patients with thyroid cancer may be, remember the words, may be considered for prophylactic central compartment dissection. That was written in 2006 guidelines. Now you need to go back to the whole publication. There were only 2 surgeons on the guideline committee. There were 16 endocrinologists, only 2 surgeons. So it was a biased opinion. It was like maybe can be done. Then between 2006 and 2009, the clinicians realized that we're doing more elective central compartment dissection with, number one, no benefit to the patient, but more risk to the patient. Nerve injury and parathyroid problems were high. So in 2009, within 3 years, the guidelines changed. And they said, now you do it, central compartment dissection, only if, as you said, larger tumor, gross extrathyroidal extension, or high-grade histology. So that was the change. And you need to go back and be more philosophical. How come the guidelines change within 3 years? That's the history behind the central compartment dissection. But what Dr. DeCruz said is absolutely correct. It is always the responsibility of the operating surgeon to evaluate the central compartment. Whatever is the term you use, evaluation or careful dissection, but you need to evaluate both the ipsilateral and the contralateral and do selective dissection or dissection only if there is strongly suspicious lymph nodes. Now, we realized quite immediately that the risk of complication was high with no benefit to the patient. That's why 2009 guidelines changed. And that is very interesting, how the committee makes the decisions. It is not uncommon, many times the committee makes a decision based on the person who is dominating the scene rather than the data provided. So there was a lot of interest in randomized prospective studies. Bob Udelsman from Connecticut wrote a paper that there won't be a possibility of doing a randomized prospective study because you'll need a large number of patients followed for a long period of time. However, there were 2 randomized prospective studies done for central compartment. Karthika, if you tell me the answer to that question, who did those, I'll buy you dinner when I visit Bombay.
But I'm not aware of that study.
That's okay. I'm not going to lose the dinner so easily. One prospective study was done by Paolo Micoli from Pisa, Italy. And the second prospective study, which was done about 5 years back by Rebecca Sippel from Madison, Wisconsin. And both of them concluded that there is no role for prophylactic central compartment dissection. Actually, the data that was published by Rebecca Sippel was there was a high incidence of complications, the nerve injury and the parathyroid problem. And as Dr. DeCruz mentioned, the parathyroid problem is the worst problem you can give to the patient with thyroid cancer. He is 31 or whatever, 35. He will be suffering for the rest of his life. So don't do unless there are grossly suspicious lymph nodes. And that's part of the reason I mentioned before, the preoperative evaluation is very critical in these patients, either with ultrasound if you are good and you talk to the radiologist, or with CAT scan, which I like to interpret, and what you see in the operating room. You also use the word very casually if there is an extrathyroidal extension. You need to define that very well. What do you mean by extrathyroidal extension? Is it gross? Is it microscopic? Keep in mind, his final pathology report, I'll give you right now, is going to show periadipose tissue involvement around the thyroid. the thyroid gland itself is 3 centimeter, 3.5 centimeter. You've got 3.4 centimeter nodule, which is filling the entire right lobe of the thyroid. The final pathology will show you minor periadipose tissue involvement or minor involvement of the tissue around the thyroid. And that's why the new staging system defined that the minor extrathyroidal extension has very little implication in the long run or prognostic significance. It's a gross extrathyroidal extension. Is the tumor stuck to the nerve? Is it invading the trachea? Is it involving the strap muscles grossly, not minor? And those are the important aspects of thyroid surgery. What you need to do when you become attending is, the first thing you want to get idea is, what's the extent of the disease? What do I need to do? Don't use a knee-jerk reflex, I want to do total thyroidectomy because that's what I read, or that's what my endocrinologist pushes me. We are going away and away from radioactive iodine. We're not using it routinely now. We use it very rarely. If we operate on, let me make it very simple. If we operate on 100 patients with papillary cancer, even with total thyroidectomy, we'd use radioactive iodine in 20 to 30% of the patients, not otherwise. We'll just monitor them. We use thyroglobulin. Our endocrinologists are going away and away from routine use of radioactive iodine. If you want to read a summary paper on this, this was written by in Journal of Clinical Endocrinology Metabolism last year by Samantha Newman and one of our attending at Memorial, Laura Bukai. It's a masterpiece writing. Exactly the philosophy when you want to use radioactive iodine and when you don't want to use radioactive iodine. The only indication that we use strongly today is major vascular invasion, more than 4 foci, because those patients are likely to have or may develop distant metastasis, which you can follow very well with thyroglobulin. Anil, it's all yours now.
Okay, so we have a question from Karthik. Would I'm modifying the question, would TSH drive your philosophy versus a hemi or total? He says that considering the TH is 5.82, patient is going towards hypo, better to do a total thyroidectomy and follow the patient with TG testing. Yes,
Okay.
no, or throw it out of the window.
Let me answer that because I think it would not be appropriate to push Karthika too much now. So I'm going to give the answer. The decision about extent of surgery is based on the extent of the disease rather than other factors like TSH, or she may be on thyroid medication before, or even presence of Hashimoto's. That doesn't change anything. Yes, this patient may require thyroid medication for the rest of her life, but remember, it is a supplement. It is not replacement. When you take the whole thyroid out, it is 100% replacement. Just imagine your own sister. She's 25. She's going to need thyroid medication from age 25 to age 95. Not easy. What we have not put in the equation, and this is very important for one of the younger surgeons to follow through, is the quality of life of these patients. Ask any patient who had total thyroidectomy and she will tell you, my life is not the same. I just don't feel well. I'm going to give an analogy. It's being diabetic. You live the same length of life, but your life is miserable because of your glucose goes up and down. You have to go to the emergency room many times. The same thing with the total thyroidectomy. We need to do good studies on quality of life of patients between total thyroidectomy and hemithyroidectomy. I am convinced, and our whole institution is convinced, that the quality of life is much better when you do a hemithyroidectomy. Yes, you may need some thyroid medication. The decision about extent of thyroidectomy does not depend on pre-op TSH.
Dr. Shah, question for you. In the memorial data, 1 to 4 centimeters hemi versus total, there is more or less an equal percentage of patients who have gone into total versus hemi. Now, the outcomes are the same: overall survival, loco-regional recurrence, recurrences, all that. How in Memorial are you all triaging which patients in this low risk group go into hemi versus total? If it was so sacrosanct, it should have been 100% hemi. But
Yeah.
yet we see about 60 to 40% in the Memorial data. So please give us the points, and this is the question in the chats. How do you all
Yeah.
triage these patients?
Yeah, these are excellent questions. Those are the root of discussion and controversy in thyroid cancer management. I must give you an addendum right in the beginning that lately, over last, I would say 3 to 4 years, we're doing less and less total thyroidectomies. We are more into lobectomies now because we have learned the biology of the disease is something that is going to make a decision. We also learned that the radioactive iodine is not going to help to prolong the life or prevent the recurrence. So that's the preamble of my discussion. Um, when do we do total thyroidectomy? In a low risk patient or intermediate risk patient, if there are nodules on the other side, which are of concern. If it is below 5 millimeter, we'll just leave it alone. If it is more than 5 millimeter, if we can get a needle biopsy by talking to the radiologist, it confirms to the patient that I don't have to worry about the other side. That's all. And in the operating room, if we find a multiple positive nodes or nodes in bilateral central compartment, then we would consider, not do, but we would consider total thyroidectomy. The $1 million question is, there are two questions. Is this patient going to be benefited by total thyroidectomy, number one? And am I doing total thyroidectomy to facilitate giving radioactive iodine? The whole idea of completion thyroidectomy or total thyroidectomy is to facilitate giving radioactive iodine. If you think the radioactive iodine is not going to help, and it helps very rarely, we would not consider total thyroidectomy. The only place where radioactive iodine has shown major impact is young children with pulmonary metastasis, where you give radioactive iodine and you see the whole lung filled with miliary metastasis. That's where the radioactive iodine helps. If you've got 4 positive nodes and there is a microscopic 5th node, radioactive iodine does not help. This is the changing philosophy of management of thyroid cancer in United States. I'm going to go a step ahead. Lately, we are doing only lobectomy and neck dissection, even with clinically apparent lateral neck disease. If the nodal disease is minimal, not bulky, not 25 nodes, but let's say there are 2 or 3 nodes at level 3 and 4, we are very comfortable doing a ipsilateral lobectomy and neck dissection. That's a philosophy which has been promulgated by surgeons in Japan, and we are now using that same analogy because we have realized that we don't use radioactive iodine routinely, and the radioactive iodine does not change the outcome. What changes is the complications of surgery, number one, and the quality of life.
So perfect. So, Sir Dr. Pradhan, any different philosophy?
No, I think that one important factor to keep in mind is that if you don't do a total thyroidectomy in cases where there are nodules in the opposite lobe or there are lymph node metastasis, I think that the patient is going to keep worrying and keep going from doctor to doctor. It's very difficult to convince such a patient about the quality of life. He's just going to be so worried about cancer. So we do total thyroidectomy if there is a nodule in the if there is a nodule in the opposite lobe, and if there are lymph node metastases. But of course, if there is distant beds, then there's no question. Total thyroidectomy has to be done.
Have we lost Sir Kanav?
Yeah, I think we're not able to hear him well.
Okay. So I just 2, 3 points to again develop a discussion on the comments made by Dr. Shaha and Dr. Pradhan. One, in the US today, if you look at any of their big series, Yuan, Brito, and all these guys, 86% of thyroid nodules treated in the US are less than 2 centimeters. So you are definitely going to do a hemithyroidectomy. So that's one of the reasons, apart from the changing philosophy, why y'all are seeing more hemithyroidectomies. It's because the cancers are diagnosed much, much earlier. So a word of caution to people from our country, what they see in the West is not exactly what we see here. So we have to put our data together. There are efforts to bring in Indian cancer guidelines for thyroid that will be able to answer that question more appropriately. So for me, it's not only the 4 centimeter cutoff. I don't go with my vernier calipers, and if it's 3.9, say I'm doing a hemi, because there's data saying that it's all the same. So you have to look at multiple factors, nodes, opposite lobe, the chance that this patient could come with high risk factors. Even if I do a total, I may not give the patient radioiodine, but I'm set and I can follow that patient well. And if I see my TG rising, I can go put that patient on radioactive iodine subsequently. Doing with the opposite lobe having nodules that look benign is sometimes scary. When you have a hemithyroidectomy done, what causes nodules are fluctuating levels of TSH. You will never be able to control the TSH at one level for the rest of life. The TSH thyroid replacement varies on 3 factors: the age, the activity, and the weight of a patient. So today, if I put my patient after hemi on 75, as he or she gets older, it might become 50. And that fluctuating levels will cause more nodules to appear or the nodule to grow. So here I put my money with Dr. Pradhan. The patient will be very panicky. You'll be poking that nodule again and again. So when you have, unless you have a very, very small 1 millimeter, 2 millimeter, but if they're multiple, even if they're small, in my book, the patient goes for total thyroidectomy. If it's one isolated small 2 millimeter nodule in the opposite lobe, I'll discuss with the patient, may come for hemi, may go for total. I'm not averse to both. It's a decision I make with my patient. So 2 quick points. I mean, we all have our own philosophy about opposite side nodules and the cutoff value for doing a hemi versus total. Back to the 2 experts, any other comments, or we'll open it to our chat group. If there's anybody who wants to make comments, add to the discussion.
I just want to add one thing, Anil, if I may.
Sure,
The,
sir.
the decisions about management of thyroid cancer is an isosceles triangle. It's a patient, the surgeon, and the endocrinologist who is going to follow the patient, or the person who is going to follow the patient. If that triangle is not complete, patients are going to get very unhappy. And patients should never think that there is a room for bigger or better treatment that I'm not getting. And that's why in United States, total thyroidectomy and radioactive iodine was a kind of reflux philosophy up until, I would say, last 20 years. What happened in last 20 years? The endocrinologists got involved more actively. They started following these patients for a long time without a bias. And they realized that the quality of life is better, the outcome is the same, so they switch quite a bit. If you see the philosophy at Memorial, it changed when Mike Tuttle joined us in around the turn of the century, around 2000. But before that, it was a standard philosophy, total thyroidectomy, radioactive iodine. As a surgeons, we didn't use that. But that was the philosophy all around the country. Now it has changed because the endocrinologists have gotten involved, and there are dedicated and devoted endocrinologists who follow patients with thyroid cancer. And you have to have a philosophy in your institution. Otherwise, the patients are going to get confused. They're going to go from you to somebody else. Somebody else says the bigger treatment is better, they will go for it. Again, that's the understanding of the biology and the philosophy of management of thyroid cancer.
Okay, great. Any comments from others who have logged in? Can you put them into your chat box? Kanav, are there anything that we have not? Okay, there's a question from Noor Malik. A word about insular variant and micropapillary. So maybe we'll just take aggressive variants as first part of the question. Dr. Shah, would you like to answer that?
Yeah, we wrote quite a bit about that. We wrote recently a paper on tall cell variety. There are various aggressive.
Dr. Shah, can I just jump in? Karthik, name aggressive variants.
Sir,
That's what I was going to say, but it's okay.
No, that I don't want you. I want you to fill in the blanks after she finishes.
it's a tall cell, hobnail,
Why do you
diffuse.
call it tall cell?
So the height of the cell is 3 times the width of
Okay. Then hobnail, then?
hobnail, diffuse sclerosing, and yeah,
There was a question, so you use that term, insular.
insular,
And one more, tell us, columnar.
columnar.
You know, it's a variant of tall cell. The whole philosophy of tall cell came from the writings of the late and the great pathologist Virginia Livolsi from University of Pennsylvania. Unfortunately, she passed away a couple of years back, but she left her legacy for us to understand the pathology of thyroid cancer. She also popularized the philosophy of microcarcinoma. She didn't like the word micropapillary carcinoma. She would call it microtumor because these patients do very well. Coming back to the question about aggressive variant of papillary carcinoma in a microcarcinoma, remember the decisions or the outcome is not one aspect of thyroid cancer. The size of the nodule, the age of the patient, is there gross extrathyroidal extension, is there bulky nodal disease, and then the last comes the pathology, and is there a major vascular invasion. So pathology is one aspect of the 5 other parameters. And if the tumor is below 2 centimeters or micropapillary carcinoma, it does not matter what the pathology is, whether it is insular or whether it is a tall cell or hobnail. We see fair number of hobnails lately, and the patients read the Google and they come prepared for second operation. They come NPO many times for second operation, and you say, hey, you don't need this.
So, Dr. Shah, to just fine tune this question for the practicing clinicians, 2.8 centimeters hemithyroid done comes with a tall cell. You will say, go back home?
We will say, we'll monitor you carefully, we'll follow with the thyroglobulin. Now, one of the questions that comes up is, how do you follow the patients after thyroid lobectomy? Very simple. Do a baseline thyroglobulin about 2 months after the surgery and use that baseline for future follow-up. Suppose the baseline is 10 and the next time it becomes 100, yes, I'm concerned about it. So can you use thyroglobulin in after lobectomy? Yes. Is it strong? No. But it can be used. That is number one. The second is use a good ultrasound done 6 months after surgery and once a year after that. And obviously, routine thyroid function tests, which will help you. Remember, the patients in whom we have done a lobectomy, they are really, truly low risk patients. And the risk of recurrence in that group is very small, less than 5%. So if you do the ultrasound 6 months later and follow regularly, I don't think you are going to lose anything.
Anyway, I have a different philosophy. If I get a patient 2.8 centimeter, it comes as an aggressive variant. I'll probably discuss with the patient, and if the patient wants to go towards total, I'll complete the total. I will not tell them that I'm going to observe and it's not going to come back, because God forbid it comes back aggressively. We'll be in deep. I would discuss with the patient, and my threshold to complete the total would be lower than what you have just said. Dr. Pradhan, your views, other seniors who have listened in, Devendra, others, can you please turn on your mics and give your
Anil,
philosophy one at a
can I
time?
ask, Anil, can I ask you a question?
Sure, sir.
You think in that particular patient, by doing total thyroidectomy and radioactive iodine, you are going to lessen the risk of recurrence? Or that is more hypothetical, philosophical, and if that happens, I want to cover myself. Is
So,
that the
so the question is difficult to answer, but I'll answer it this way. I'm very clear in my mind that aggressive variants have a poorer prognosis than the garden variety papillary cancer.
Yeah, I understand that. But by
I, I,
taking out the
I
other
have,
lobe and giving
so if I
radioactive
have a
iodine,
patient, even if I have a patient where I know the BRAF and it's positive, it may not be standard of care, but I would then veer towards total thyroidectomy. I don't go 4 centimeters. If I've got, if it's a 1 centimeter, it's unlikely to be a tall cell. 3.8, I'm not going to say you're 2 millimeters away from 4, so I'm going to observe you. If I know it's a tall cell, 3.8, it's total in my book. I'm not going to convince them that nothing's going to happen to you. It's total. So there's no definite answer to this. I mean, we can keep discussing. There's no data, unfortunately, in thyroid. Randomized data is very, very little. But we do know that these are bad cancers. And if you read the ATA guideline, every second page is the patient should be taken into confidence. It depends on the philosophy of the treating institution and dot, 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 dot. Even if you see 1 to 4 centimeters in ATA, it again says if the doctor feels that you may need radioiodine, total thyroid, it gives you 5, 6 escape clauses. So mine is I would do that in total. Dr. Pradhan, your views. Aggressive variant 3.5 centimeters comes to your clinic for a second opinion.
Total.
Total. Devendra Chaukar.
So it will be total because current ATA guidelines as per 2015, one of the criteria for upstaging to intermediate risk is a aggressive variant. A tall cell variant goes into the intermediate risk, where currently radioactive iodine may be given to this patient. So for me, it will be total thyroid unless we are changing these guidelines and including these tall cell and other variants into low risk. But as of now, it is intermediate risk.
So I guess the take-home message for everybody is that generally aggressive cancers, you must do a total and observe your patient. But yes, Dr. Shah has made a very, very compelling point that don't hit the panic button. Look at all factors, including size and various other things. So if you get a 1 centimeter purely intrathyroidal, you're not sure of the histology, they say maybe tall cell, you don't have to hit the panic button and rush into surgery to do a completion. A question from Kinshuk Chatterjee. Would you look at the percentage of tall cells to drive your philosophy of hemi versus completion?
I would not, but I just want to give the first answer to the first question. What is tall cell? And if there is more than 30% tall cell population in that histopathology, that is considered as a tall cell papillary carcinoma. And where did that number come from? It was just a judgment of the pathologist. And again, it goes back to Virginia Livolsi, who popularized that. Her colleague, Zubair Baloch, he's an outstanding cytologist and pathologist, has written extensively, and he was the pioneer of Bethesda system in United States. The name is Baloch, Zubair Baloch.
Okay, so Kinshuk, I'll answer your question. If it's more than 30%, as Dr. Shah said, you will go in. It is a tall cell. And in my philosophy, Dr. Pradhan's, Dr. Chaukar, and maybe others, if they turn on, we would do a total thyroidectomy in this patient. However, please do not hit the panic button when you read a report, a papillary thyroid cancer with an occasional tall cell. Don't rush to do a completion thyroidectomy. I hope that answers your question. Any other questions in the box? Any other seniors want to make a comment? Please turn on your mics.
Iftikhar, are you there? Iftikhar?
Yes.
Is Iftikhar there? I saw him sometime back in the.
No, your voice is not clear. Please, let's not waste time. Come close to the mic if you can speak quickly. Otherwise, type your answer in the box.
So
Who is
can I ask a question, sir?
Yes, Noor, go ahead.
Sir, in the given situation, if the follow-up is a trouble, like we have a lot of international patients who cannot come up for follow-up. So what will be the decision then, hemi versus total?
Oh, that's a very, very tricky question. I can see Dr. Shah smirk. He's got his answer ready. So we are going to get the US philosophy, and then, sir, Dr. Pradhan, we are coming to you because you do a lot of international as well. So we want to know your views, and maybe Devendra, you as well, Satakshi, you too. Go ahead, Dr. Shah.
Well, I just want to go back again. The philosophy of management of any cancer is based on the disease, not the paraphernalia. He comes from foreign country. Now, I would put it a different way. He comes from foreign country. He's going to suffer with total thyroidectomy, taking thyroid medication for the rest of his life, adjusting thyroid medication, and getting unnecessary scanning, etc. So you can put it in a different angle. Yes, but you have to realize one thing: getting a peace of mind or feeling better or saying I did a bigger operation is not the care for cancer. If that was so, we would have done many total glossectomies, we would have done many total colectomies, we would have done many total gastrectomies. We don't argue there. We argue with the thyroid. Why? Because we love to argue about it.
So quickly, Noor, Dr. Shah's question is the place from where the patient comes does not drive his philosophy on deciding on whether the patient should have a hemi or a total. Dr. Pradhan, Devendra, Satakshi, all of you all see international. Any of you all want to make a comment? Sir, you first, please.
No, I agree. If it's a low risk cancer, there is no reason to do a total thyroidectomy.
Noor, does that answer your question? Okay.
Yes, sir.
Devendra, anything comment? Satakshi, a comment?
No, sir. Dictated by the biology of the disease.
Okay, great. Satakshi?
Yes, I agreed on the same what Ashok sir mentioned, triangle of considering patients' variables, tumor variables, and then the choice, all three.
Okay, great. Abhilash, your question I think is answered. 1 centimeter FNAC atypia AUS, that's a Bethesda 3. We'd probably observe the patient. We wouldn't rush in and do surgery. Kanav, you've got a case. Kartika, now I'm going to give you the pleasure of asking Dr. Ashok Shah and Dr. Sultan Pradhan one question each. You're the candidate, but you get, because you did so well, you can stump the masters.
Be kind to me, Karthika.
Yeah, seriously, if there's any doubt in your mind, something that you had read and we've not asked you, something that's a doubt in your mind and you were hoping we don't ask you, please ask them. You'll never get these two masters on one stage for a long time to come.
Sir, I just wanted to ask that there is a modified risk stratification which the ATA has written, and then there was the old risk stratification. So if we are if you're going to do if you're not considering the patients for a radioactive iodine in terms of these risk of recurrence, then what is the point of putting up that aggressive histology in intermediate or further?
Well, the answer is very simple. These risk stratifications are the philosophy of the institution of the surgeons. If you go back to the risk stratification, which started the first paper was published in 1979 by Bayer from EORTC, and then it came to Mayo Clinic and Leahy Clinic, which they divided the patients into low risk and high risk, 80% against 20%. At Memorial, we had the database, so we looked at it very critically and we said, hey, the patients don't belong to low and high risk. There must be something in between. And that's why we came up with the intermediate risk group. And even in intermediate risk group, we divided into two, the young people with bad cancer or old people with good cancer. So that's how the genesis of the intermediate risk group came. And the philosophy of treatment changed in each risk group. So universally, in the low risk group, we are very comfortable with limited surgery. In the intermediate risk group, it's a decision making based on what are the factors involved. Now, size is not the alone factor. There are many papers in the recent literature going up to, you do a hemithyroidectomy, the final report shows 4.5 centimeter thyroid cancer. That doesn't make bad intermediate risk. And that's why the paper that I mentioned by Newman and Bukai describes even in the intermediate risk group, there is a low side and there is a high side. If there's a major vascular invasion, that's a intermediate risk group, but high side for considering total thyroidectomy and RAI. What we need to appreciate is my treatment going to change the risk of recurrence? And yesterday only I made a comment in one of our thyroid conferences. Keep in mind, any patient who walks in your office with any cancer, it is not only thyroid, tongue cancer, colon cancer, there is a risk of recurrence given in that particular cancer. The risk of recurrence in tongue cancer may be 10%. For thyroid cancer, 5%. What we need to develop a philosophy is, can I bring that risk from 5% to 1%? And is there a treatment that will change from 5 to 1? If it is there, then we'll go for something more. If it is not there, every patient with cancer needs to know that he is stuck for the follow-up for the rest of his life. And whenever there is a recurrence, you take care of it based on the kind of recurrence that you are seeing. Can we certify every patient that he is cured? Probably in the low risk group, yes. In the intermediate risk group, we need to monitor the patient.
Yes, sir.
Sir,
Go ahead, Sultan.
Dr. Pradhan, any questions? Any comments? Sorry.
No.
Okay. There are other questions that are coming into the box.
Wait. Karthika was going to ask a trick question to Dr. Pradhan.
Okay.
Yes, sir.
Now you've got your ticket to Amrita, so you can do it. Go ahead,
No,
Karthika.
sir. Sir, I don't have. So one more I wanted to ask is, in the thyroid cancers, why is it that the TSH is just at the borderline of the upper reference range? Like that's what I wanted to.
You mean to say pre-op or post-op?
So usually, pre-operatively, when you see in thyroid cancers, they're either euthyroid or it's on the TSH is on the upper part of the reference range. So I wanted to know, like, is there a reason why is it like that? Like, why do we find TSH on that
The
level?
thyroid continues to function very well.
Okay.
You need very little thyroid to function well. That's why many patients with lobectomy may not need thyroid medication. Sorry, Dr. Pradhan, I took your answer.
Good, thank you.
So did you understand, Karthika?
Yes, sir. The remnant thyroid functions well to keep.
No, but your question was something else. Her question was, why should nodules that are towards hypothyroid be malignant?
Mhm.
Why should malignant nodules have a raised TSH? That's your question, right?
Yes, sir. Yes, sir.
Then where was the answer? So that's the girl's question. That we are told that if you have a TSH of 5, 6, 7, and you have a nodule, suspect malignancy even before you see the sono and stick your needle in.
I'm not convinced with that philosophy.
Devendra, anything?
No, so I think it's the other way, maybe not be this, but the other statement where hyperthyroid nodules which are hyperthyroid have a lower incidence of malignancy
No,
rather
but
than
no, it is proven without doubt that if you have a high TSH
I
malignancies,
don't know the reason for that.
it's not grossly hypothyroid. I've searched for the reason. It's quite simple and intuitive to me. So God gave us 2 lobes of the thyroid, which are 25 grams. If you have a nodule sitting in there which has eaten away 12 grams, then automatically there'll be less thyroid hormone being produced. This is my logical reason. I've not read it. So that's why they have a tendency towards being hypothyroid.
But why should it be malignant? A benign nodule should do the same thing.
It is just an observational study. That
That's
when
okay.
it's observational, it's quoted very strongly in ATA as well, that if you have hypothyroid, which is not myxodematous, those nodules have a higher incidence. If you look at euthyroid, if you look at hyperthyroid, and you look at raised TSH, the raised TH, the incidence of malignancy is higher than the other two. It's quoted in ATA when you work up and look at triaging nodules towards malignancy. But maybe some of the youngsters can check. It's been years since I've read, and if I'm incorrect, they can just send me a message, but send it offline, privately. Don't put it in the big group. Karnav, over to you. I note that you've got a 15 minutes vote of thanks. I've been for 2000 functions. I've never seen someone do a 15-minute vote of thanks, but I know you have to thank Dr. Shah. It's been great. Kartika has been wonderful. And of course, Dr. Pradhan. So your 15 minutes may run short. Go ahead with your vote of thanks, and we'll finish on the dot of 7.
So can I ask a question?
Yeah, please.
I'm deviating from the topic today, but a little clarification. In the pediatric age group, say a 16-year-old, does the size criteria hold the same as in adults? So if you have a 16-year-old with a 4 centimeter nodule, will you treat that as an adult without nodes, obviously, just by the size criteria? Will you treat it as the adult, or would you do a total thyroid in the pediatric age group?
That's a great question. Is it Devendra? Yeah, Devendra, that is the great question. And if you look at the pediatric thyroid cancer guidelines, again, there is a separate guidelines for pediatric thyroid cancer. The problem is, remember, the 16-year-old, what's the difference between 16-year-old and 18 or 19-year-old? And that's why the new guidelines which will come out in near future will treat these patients like adult patient. Combiningly, they are called as adolescent thyroid cancer. And I personally would not change my philosophy between lobectomy versus total thyroidectomy because it is a pediatric, unless the kid is below 10 or the tumor is very large and there is a high incidence of nodal metastasis. Otherwise, my philosophy does not change because he's 16-year-old.
Thank you, sir.
Anyway, Devendra, quickly, I agree with Dr. Shah. We won't change our philosophy when we treat a pediatric thyroid cancer, but you have to keep at your back of your mind, multicentricity is known to be higher when you have a ped kid. So if you have a kid less than 12, largish nodule, my, again, personal philosophy is to push towards a total, but please make sure you don't screw up the parathyroids and the nerve, because the parathyroids are very difficult to find in kids. But multicentricity is slightly higher, but though it may not drive my philosophy. So I think at the end of this meeting, what I learn is that you have to not, there's no sacrosanct answer in thyroid. put all your facts together, look at imaging, look at patient comfort, look at your philosophy, your institution philosophy, understand the most important point that Dr. Shah said at least 5 times in his talk, the biology of the cancer, and then drive your philosophy into treatment. No less than 4 centimeters definite hemi, more than 4.1 definite total. So just use your discretion before you operate the patient. And I think some very excellent points by Dr. Shah that even if you have 1 or 2 nodes, because I've seen patients who have a hemithyroid, it comes as 2 nodes juxtaposed to the thyroid, show small focus of papillary, and they rush the patient into the operating room the next week to do a completion thyroidectomy, saying it's node positive. And I think he said very, very clearly, limited volume nodal disease, you can still get away with hemithyroid. So these are important learnings for many people who are listening to us today. Don't push your patients towards a total. Understand the biology before you make your decision. Any other comments? Then we'll hand Kanav. He's all ready with his vote of thanks. I can see 5 pages.
Don't you have some interesting cases to present?
Kanav, you want to do that? Sir, we have come to the hour of 7. That's why I thought but it's up to everybody. It's absolutely fine. Kanav, you want to do a case? Go ahead.
We can, I'll present it in brief, sir.
Okay, go ahead. But Kartika, great show, huh? Congratulations. Very, very well presented.
Thank you very much, sir. Thank you very much.
Where did you get your training, Kartika?
Sir, HNCI.
Thank you.
Do you know Dr. Pradhan? He works in agency.
Sir, but this was more my kind of style, sir. How did you do this today?
I heard you last time at the
Gallops.
Gallops. Yeah.
Okay, go ahead, Kartika. I mean, sorry, Kanav.
So this was actually a lady who came to us. She's a relative of a colleague of ours. She came to HNCI for a routine examination, blood work, and since she was in the hospital, she got a routine sonography of the neck done. At the sonography, they found that she has a left TO groove lesion. She has a and she was asymptomatic, completely asymptomatic. These are images of her. These are images of her sonography where we can see that we can see that the thyroid gland is well seen over here. This is the left lobe of the thyroid, and there is this hypoechoic lesion that is seen medially, medial to the thyroid, deep to the thyroid. This is the trachea over here that we see, and this was this hypoechoic lesion that was picked up on the sonography. So the next thing that they did was they got a CT scan done, a contrast enhanced CT scan done, which showed that there was this lesion that was enhancing in the left tracheoesophageal groove. As we can see in the post-contrast image over here, there is enhancement seen in both lobes of the thyroid, which is seen in a normal thyroid gland, as well as some heterogeneous enhancement in the left tracheoesophageal groove over here, as well as some invasion of the trachea that is seen over here. And these are further images, coronal and sagittal images, where we can see that there is this growth seen in the left tracheoesophageal groove, just about at the level of the cricoid, starting at the level of the cricoid cartilage, extending lower down till about the first or second tracheal rings. And this was a 0-degree scopy that we had done, which showed that there was a bulge that was seen in the left posterolateral wall as well as posterior wall of the trachea. This is just about at the level of the cricoid cartilage, extending inferiorly. So I would like comments from Dr. Shah and Dr. De Cruz.
I guess first, do we need to have more investigations on this person? So here you've got a thyroid sitting, in my opinion, in the region of the thyroid, and it's bulging into the trachea, larynx, stroke, trachea, and this looks to me like a Shin's 3.
Sir, on the sonography, they felt that there was a well-defined plane and this lesion was separate from the thyroid gland, sir.
So it's a separate mass.
Yes, sir, separate mass.
So you have a
The
thyroid.
well-defined plane over here where there is a plane between the thyroid and the mass.
Did you biopsy? Did you do an FNA?
Yes, so the next thing that was done was a FNA and a biopsy under ultrasound guidance, which showed that this is actually just benign thyroid tissue.
No, but go back to the CT cuts. To me, it looks more or less in continuity.
Okay, sir.
Look at this here. Yeah, here I can see a kind of a plane, but look at this here. I'm not sure I would pass this off as a separate mass. And it's bulging nicely there. It looks like there may be a millimeter. There may be your nodules are known to kind of come out. Like you can have it need not be within the capsule. You can have nodules out. But in this case, I'm scared because this is like a Shin's 3.
Yes, sir.
This is not normal thyroid causing pressure.
And the biopsy is benign thyroid or?
Yes, sir. Benign thyroid is what they reported.
So what biopsy did you do? An FNAC?
Both FNAC as well as a core biopsy was done, sir. Both showed.
Okay, I will first open it to Dr. Shah, maybe Devendra, Satakshi, I can see you there. If you all want to do anything else, then I can make my comments after that. So, Dr. Shah, would you do something different?
No, I think, he has done a complete workup. The only one other imaging might be of little bit more help is a MRI.
MRI.
MRI may help you to guide. Now, your biopsy was benign. You did 2 biopsies, one point needle, one core biopsy. If for any reason you have decided not to operate on the patient, I would repeat the biopsy in few months. You want to be absolutely sure this is a concerning lesion. Part of it is in the subglottic area. So you have to be prepared emotionally and practically what you want to do if it is a malignant problem. Can you get a benign thyroid tissue in that area? Yes. Is it very common? Very rare. Even intratracheal benign thyroid tissue is well known. But those are case reports. Once, if this turns out to be benign, it is a good case report for a major journal. They will accept it because this is very rare and the decision making is very complex here. And you are afraid that when you take this patient to the operating room for whatever reason, you don't know what exactly you will do and what is the likelihood of making a hole in the subglottic area.
Devendra, any comments?
No, sir, whatever Dr. Shah said. Just what was the cord status? Because this is in the TO group.
Freely mobile.
Freely mobile. Yeah. So no, yeah, just an MRI. If the MRI is showing no esophageal involvement, we'll need to do surgery for this patient.
No, but why surgery if it's benign?
Because the clinical characteristics, I don't think it's benign. We'll have to have tissue diagnosis to call it benign.
But he's done a true cut. He's done a needle test.
Cannot have sampled the right area, sir.
So that's a very important point that FNAC and your true cut may not have 100% accuracy. Yes, it will be upwards of 90 if it's malignancy. Dr. Shah's point is also very well taken that you can have ectopic thyroid tissue. So this could be an ectopic. And the reason that you are presenting it is because it's probably an ectopic benign disease with your FNAC. So this is a curiosity, but I would be very careful because this to me looks like a Shin's 3. So in my philosophy, I would probably scope the guy and look at doing an E-bus from the inside to be 100% sure that this is a benign disease. Or I would follow this patient much closely, like Dr. Shah said, and make sure that it is truly benign. I'd also ask for thyroid function tests because sometimes when these little things hypertrophy in middle, they're going towards hypothyroidism. You give them a little dose of L-troxin and this thing will shrink. I won't give it if the report is normal.
So, sir,
So,
thyroid
quick question.
functions are normal.
Pranav, a quick question.
Yes,
Even
yeah.
if it is benign, sir, if you consider the FNAC to be true, do you want to observe this considering that it has already infiltrated into the trachea and it may grow and cause further damage? So, do you want to really observe this or you want to get this out?
Oh, I'll stick my neck out and say this lady just walked into the clinic. I can make out from his presentation that she's just walked into the clinic and she's asymptomatic. So if it's benign and benign disease is known to be in the trachea, you can, in the old days, there used to be a philosophy that intratracheal disease was arising in embryonal cell rests of the thyroid within the trachea, these benign diseases. So I'm not sure she definitely needs surgery. What will you do? You'll do a laryngectomy for benign disease, or you'll do a tracheal resection for
No,
benign
we'll
disease.
shave it and send it for. If
And
it's
then,
benign, it'll come out.
and then if you
Be a
screw
problem.
up,
If it's benign, it'll come out without any tracheal damage.
no, you can damage the cord, Devendra. This is right in the TO groove. I won't touch it, and it's going up into the cricoid.
At some point of time, this patient will require surgery. Is my reading.
At least
Given
I
the growth, given the situation of the benign disease,
uh,
and given the tracheal invasion. So,
again, I'll stick my neck out, but I'll turn it back to the other two. I will follow this patient if I'm sure it's benign, but comments. The point of invasion of a thyroid cancer signifies its worst histology. So you can have a variegated disease of differentiated and you can have polycomponent. The polycomponent is the one that will invade or fix the cord or do something else. So I would definitely do an MR and I would consider, if I'm not sure on MR, I would stick a needle in through the trachea just to be 100% sure. Alternatively, I'll keep this patient on close follow-up, no surgery to biopsy to make sure it's benign. Dr. Pradhan, that's your
Kanna, I think an MR is also done.
Yes, sir. An MRI was done, and they said the fat planes with the esophagus were well maintained, and her thyroid functions were within normal limits. TSH was okay.
Okay.
I
Dr.
have,
Shah, any change? Sorry, sir. Please go ahead, Dr. Pradhan.
I have told him to keep her at follow-up, but I'm very restless what to do. So I told him we'll reassess after about 3 to 4 months with repeat imaging. I didn't think of an EBUS biopsy from the endotracheal part.
You know, so if you go back to your endotracheal picture. See, sir, I don't know, maybe it looks like a bulge, but this thing looks a little inflamed, the mucosa. So I'm not just from that point of view.
I'd rather not disturb the
Yeah,
endo.
then it's perfect, sir. So I would agree with either school of thought. I would go ahead with the observation, or if I felt I've not seen this patient. Sometime when you look at these patients on the endoscope yourself, there's some subtle signs that the tracheal wall is infiltrated. Like you see loss of mucosal rippling, various other characteristics that can signify that it could be malignant. In that case, I would do EBUS. This posterior swelling to me looks very benign. I won't hit the panic button with this, but this lateral swelling to me is a little dicey, but I won't fight. So if you're observing, I would agree. There's a question in the chat box, any role of doing a thyroid scan? Kanav, do you want to answer it? Why didn't you do a thyroid scan?
Sir, it would not really add any more information to to what we already have. We have normal thyroid tissue, and we've FNAC'd this. This is thyroid tissue. A scan would
Yeah.
add.
So I think, Manish, your answer is given by Kanav. One of the indications of doing isotope scans is ectopic thyroid. But in this case, he's stuck a needle in, he's confirmed it's thyroid. it's going to take up your dye. So it's not going to change our management. So we normally do this scans in a mediastinal isolated ectopic thyroid. We do it when we have a lingual thyroid to be sure. But in this case, I'm not sure it would add anything. So I would go with Kanav and just observe this patient. Someone, Bipin, I think dinner is ready. Your wife's beckoning you.
Oh, sorry, sir. That was an accidental.
Okay, no problem. Kartika, can you turn on your mic?
Yes, sir, it's on, sir.
Put on your photograph. Let's see you.
Yes, sir.
Tell us the locations of ectopic thyroid and why do you get ectopic?
Sir, from the base of the tongue, along the descent of the thyroglossal duct
Can
tract.
you be more specific on the base of the tongue? What's that area called?
So
MCH. MCH you're going, huh? Not MBBS.
the vallicular.
Vallicula. It's called FC.
So,
Where does the thyroid develop? At the foramen cecum, no?
foramen cecum, foramen cecum.
So it's bang in the center. It won't be in the vallicula. So you can see a lingual thyroid then. Where else can you see ectopic thyroids?
So,
You said you are trained in HNCI, right? And this is your case. Sorry, sir, I couldn't resist. Go ahead, Kartika.
some mediastinal and
Excellent. So the answer the examiner is looking at, it's along the thyroglossal line where the thyroid develops and when it descends into the place. So anywhere along that line, that thyroglossal cyst line, you can get ectopic thyroid. But it's also described in the submandibular region. It's also described in the mediastinum. And if you look at reports, it's even subdiaphragmatic. So my last question to you, which is a prize question, and then really we'll give you a prize. What's the difference between stroma overi and an ectopic thyroid?
so the stroma overi will have ectopic. Sir, I don't know.
So did the thyroid get into the ovary?
No, sir.
From foramen cecum?
No, sir.
So it's not an ectopic location. A stroma overi is a pure teratoma, like you get teratomas elsewhere in the body.
Okay.
So you will have thyroid elements in that, but that's not called an ectopic thyroid.
Okay.
Okay?
Yes, sir.
Great. Kanav, back to you.
Yes, sir. So we've kept this patient on a close follow-up and we'll reassess her after about 3 to 4 months now.
Perfect.
Sir, Dr. Teja here. I have a small doubt. Can we do, Digru sir, can we do TG washout for the FNA? Is it going to yield any result?
For a benign thyroid?
Uh, there are two samples, he told. There are two nodules. If they are taking a separate, if they have done two biopsies, why don't we see for the washout?
So what happens if you stick a needle into the thyroids and you wash it out? What will it say? It will say that there is thyroglobulin in that, no?
Yes, sir.
Why should this vary? We do TG washouts in some doubtful nodes and other things where you're not really sure of the pathology. Here, this guy's got two good biopsies. So in my book, it's unlikely to change my management at all.
Thank you, sir.
Because he's got a biopsy, it's much more accurate than doing a washout on TG. Professor Vaidya, any comments? I see you have typed something very tricky. Abhishek Vaidya? No, okay. Okay, Kanav, back to you.
This was the case I had, sir. If there are any other cases or any other questions, we can take those. Or I would like I'd request Pradhan sir to with the closing comments.
No, I think it has been very stimulating, fascinating performance by Kartika and extremely well judged by Anil and Ashok both. I wanted Kannav to participate more, but I don't think you got a chance. So this has been the first of our online educational efforts from the HNCI, and very grateful to Ashok and to Anil for initiating this. We are going to come up with some more. Kannav will keep announcing the other sessions that will come out from the HNCII. One of the first thoughts that I had when I wanted to have the Head and Neck Cancer Institute of India was that we should have good formal education from this institute, because in those days when I first conceived, there was really head and neck cancer was very little attended to in the country. Subsequently, a lot of other people have come up, and Tata Memorial is doing a great job, and a lot of other institutions are doing it. But we need to continue to do this more and more. And I'm very grateful to Ashok and Anil to kickstart this effort. Thank you. I think Kannav is going to come up with a couple of sessions now where there will be panel discussions on laryngeal cancers. Kannav, you want to announce those dates or?
I'll share that soon, sir, once we finalize the dates. But towards the end of the month is probably when we'll have the first panel discussion on laryngeal cancer, and we'll share further details once we finalize.
If I can just make one closing comment, Dr. Shah, outstanding. Dr. Pradhan, your leadership absolutely well appreciated. I've seen a lot of webinars to see close to 200 guys log in on a Saturday evening, bears testimony to the standing of two of y'all, and Kanav excellently put together. Of course, Kartika was a showstopper, so congratulations to you as well. I think everything went very well, and I enjoyed myself and I learned a lot. So thank you for having me on this show.
Thank you.
Just want to add, Sultan, you have done a fantastic job developing the institution and training a large number of head and neck surgeons around the country. We're very proud of your achievement, and this is wonderful, and we'll be very happy to help you anytime. I just want to say, Anil, you have done a fantastic job. Your name is a household name around the world. So, and your moderating skills and expertise and conveying the summary message to the audience is exemplary. So congratulations. Kanav, keep doing what you're doing, and Kartika, all the best.
Thank you very much, sir. Thank you all of you so much.
Thank you, sir.
Okay, thanks. Bye.
Bye.
Bye, everybody.
Bye-bye.
Bye, Sultan.
Bye, Ashok.
Sir, if I can ask you, is Iftikhar
Yes.
Is Iftikhar from PAKH Karachi?
Yes, Anil.
Oh, what a pleasure. I'm seeing his name after years. I went.
Hello.
Iftikhar, if you are there, can you put your camera on? Or maybe he's vanished, but lovely. I saw him many years back when we lectured there.
He sent a message right in the beginning. He was the first to send a message that I'm attending the meeting and look forward to this. And I responded to him. It's great to see him after a long time. I don't think we have met each other for almost 20 years since I visited Karachi.
He's a historian now.
Yes, and his presentations are just superb. The history that he has detailed in is just wonderful.
So it's lovely. Another positive of such webinars, you get renew old contacts.
Yeah, good.
Okay, thanks everybody. Thank you.
Devendra, great seeing you again. We didn't see you, but we heard you, and that was wonderful.
Thank you, sir. It was a great webinar, sir. Lovely. Learned a lot.
Bye, everybody. Bye.
Bye-bye.